Welcome to Monday Morning Panic. This is your highly concentrated, fast-paced review designed to give you the critical information you need for your nursing school exam. No time to spare. Let's jump right into the essential facts.
Exactly. We've distilled this down to pure, high-yield knowledge. Let's hit the ground running with diseases of the primary digestive organs.
Okay, first up, peptic ulcer disease, PUD. When you're differentiating pain, remember this crucial distinction. Duodenal ulcer pain is often relieved by food. Food kind of buffers the acid.
Right, but gastric ulcer pain, that gets worsened by food because digestion just stimulates more acid right onto that damaged lining.
And the most common cause, you'll almost always see H. pylori infection.
Definitely. But a critical complication you must recognize is perforation. Think sudden, severe upper abdominal pain and a rigid, board-like abdomen.
That's an immediate surgical emergency, absolutely.
Recognize it fast.
For bleeding signs, you're looking for hematemesis.
Yeah.
You know, that classic coffee ground vomit.
Because the blood's been partially digested?
Right. Or melena, those black tarry stools, shows bleeding higher up. And remember, NSAIDs are a key medication to avoid. Big time increase in bleeding risk.
Absolutely. Pharmacologically, to get rid of H. pylori, it's triple therapy, or CAP, clarithromycin, amoxicillin, and a PPI.
That mnemonic Claritin Mox potpourri can help.
It does. And don't forget, lifestyle stuff smoking is a major risk factor. Advise small, frequent meals.
Okay, moving up a bit. Gastroesophageal reflux disease, GERD, core problem. A weak or incompetent lower esophageal sphincter, the LES, gate isn't closing right.
Yeah, basically. So key interventions. Elevate the head of the bed, like 4 to 6 inches. Avoid eating 2-3 hours before bed. Stay upright after meals.
Dietary triggers, you got to tell patients to avoid caffeine, fatty foods, chocolate, peppermint, and alcohol. Those relax the LES.
And what's tricky sometimes is the atypical presentation in the elderly. They might get chest pain, maybe mimicking an MI, or respiratory symptoms like coughing or wheezing, not necessarily classic heartburn.
Speaking of classic, the hallmark symptom is pyrosis. That's just heartburn. Farm-wise, antacids for mild stuff. PPIs, like omeprazole, they reduce secretions, promote healing.
But long-term PPI use does increase osteoporosis risk, something to keep in mind.
Good point. And H2 blockers like famotidine, Pepcid, also used. Cholinergic meds can sometimes help increase sphincter contraction.
And the serious complication you need to watch for from chronic acid exposure is Barrett's esophagus. It's precancerous. So managing GERD is vital.
All right, let's pivot to some critical pediatric conditions, starting with cleft lipollet. Feeding technique is key. Use a special compressible bottle, long nipple.
And critically, feed the infant upright. Always upright. Burp frequently, too.
Post-op for palate repair, position the infant on their side. Helps with drainage.
Right. Nursing considerations. Daily weights, strict IO. Suture line care means gently cleaning with sterile water or saline after every feed.
And a big one. Avoid pacifiers or hard objects like spoons, straws, post-repair. Protect that suture line. Might even need restraints.
In long term, these kids have increased risks for otitis media, hearing loss, maybe speech issues, dental complications too.
Okay, next, pyloric stenosis. The unmistakable hallmark sign, projectile vomiting. It's non-bilious, gets progressively forceful, really shoots across the room sometimes.
In the classic physical finding, you might actually feel a palpable olive-shaped mass in the epigastric area, just right of the umbilicus.
You'll monitor closely for reduced diaper usage dehydration sign and a plateau in weight gain.
That persistent vomiting leads to serious metabolic trouble, metabolic alkalosis, dehydration, and hypokalemia.
And characteristically, the infant is really hungry and irritable right after vomiting, like surprisingly so.
Pre-op, number one priority is correcting that dehydration and electrolyte imbalance. 4A fluids are key. You'll also insert an NG tube for decompression.
You might even see those visible peristaltic waves moving left to right across the abdomen.
Post-op feedings are strict. MPO until the surgeon gives the okay. Then start slow. Small, frequent clear liquids, advances tolerated.
And you must report any fever over 101.3 Fahrenheit, or if vomiting continues after clear liquids are started.
Okay, bowel obstruction. Key difference in presentation. SBO, small bowel obstruction, rapid onset, lots of vomiting. LBO, large bowel obstruction, more gradual, marked abdominal distension.
All sounds tell a story. Early on, they might be hyperactive and high-pitched, that tinkling sound as the bowel tries to push past.
But late stage, or if there's paralysis, they go absent. And with SBO, the vomitus can even progress to smelling fecal. That's a bad sign.
Priority interventions are immediate. NPO, NG tube for decompression, IV fluids. And remember, there's a high risk of dehydration in SBO.
A life-threatening complication is strangulation. Blood supply gets cut off. Signs are ominous. Fever, tachycardia, severe continuous pain. That's emergency surgery time.
These patients are also high risk for fluid and electrolyte issues like dehydration and hypokalemia. The pain itself, usually severe or colicky, comes in waves.
Moving to appendicitis. Classic pain progression. Starts kind of vague, periumbilical around the belly button.
Then, bam, it migrates and localizes to the right lower quadrant, RLQ, right at McBurney's point. That localization is key.
And here's a critical warning. Never apply heat to the abdomen. You could cause a rupture.
And ironically, a sudden stop in pain, that's usually bad news, likely indicates rupture and peritonitis.
For comfort, have them lie still, knees flexed. Diagnostics show leukocytosis with a left shift, more immature white cells.
Key sign on assessment, rebound tenderness in that RLQ.
Pre-op. Keep NPO. Absolutely no laxatives or enemas.
Okay, on to celiac disease. The core issue is autoimmune. Gluten wheat, barley rye damages the small intestine villi, screws up absorption.
And the only extra treatment is a lifelong 100% strict gluten-free diet. Emphasize, no medications for celiac itself.
Hallmark symptom is steatorrhea. Fatty, foul-smelling, floating stools, that's the malabsorption.
Now here's a critical point for diagnosis, often missed. The patient must be actively eating gluten during the workup. If they've already cut it out, the test might be falsely negative.
Good point. You also need to teach about hidden gluten sauces, gravies, soups, even meds.
And they're at risk for nutritional deficiencies. Anemia from low iron folate, osteoporosis from low calcium vitamin D. Also, sometimes a skin rash called dermatitis herpetiformis.
Let's break down inflammatory bowel disease, IBD. Includes Crohn's and ulcerative colitis. For both, advise avoiding cold foods, smoking.
Diagnostic tests for both typically show elevated ESR and CRP. A colonoscopy is usually needed to confirm.
Okay, the difference is Crohn's affects any part of the GI tract, mouth to anus. It's in a skip lesion pattern, inflamed areas next to healthy ones, usually spares the rectum.
Appearance is transmural inflammation, all layers, gives that cobblestone look, high risk for fistulas, abscesses, strictures. And key point, surgery is not curative for Crohn's. Diarrhea is typically non-bloody.
Contrast that with ulcerative colitis UC, limited to the colon and rectum. It's continuous, starting at the rectum and moving up.
Hallmark symptom. Bloody diarrhea, that's the primary sign. Inflammation is superficial, just the mucosal layer.
Big difference. Surgery, a total proctocolectomy, is curative for UC.
But a major life-threatening complication for UC is toxic megacolon. Gotta watch for that.
All right, shifting gears. Diseases of the accessory digestive organs. Starting with hepatitis. Classic physical findings. Dark, tea-colored urine and then clay-colored colic stools.
Right, that's all due to impaired bilirubin metabolism. It's not getting excreted properly.
Post-liver biopsy, positioning this is critical, immediately put the patient on their right side. Applies pressure, prevents bleeding.
Dietary management. Low-protein diet if encephalopathy is present to cut down ammonia. And the patient must avoid alcohol. Absolutely.
And since the liver makes clotting factors, these patients have a high risk for bleeding. Soft toothbrush, monitor for bruising.
Remember transmission. Hepatitis A and E are fecal-oral, bowel for bowel. Hepatitis B and C, that's blood and body fluids.
Key labs will show elevated ALT, AST, bilirubin, and ammonia.
And patients often get pruritus, intense itching from bile salts building up under the skin.
Moving to pancreatitis. Core problem, autodigestion. The pancreas is literally digesting itself with its own enzymes.
The hallmark pain for acute pancreatitis is severe, boring epigastric pain that radiates straight through to the back, often relieved by leaning forward or sitting fetal.
Chronic pancreatitis pain is more intermittent or constant dull pain, LUQ radiating to back, often worse with fatty foods or alcohol.
Priority intervention for acute pancreatitis, strictly NPO. Rest that pancreas completely.
Watch for critical signs of hemorrhage. Cullen sign, that bluish color around the umbilicus, or gray Turner sign, bluish on the flanks.
Key labs. Serum amylase and lipase will be way up. Lipase is more specific for the pancreas. Monitor electrolytes closely, especially for hypocalcemia. Watch for Schlossek's sign.
And patient education is crystal clear. Absolute abstinence from alcohol. Mandatory.
Next, cholelithiasis, gallstones, and cholecystitis, inflammation, classic pain, biliary colic, severe pain, RUQ, often radiates to the right shoulder or scapula, usually after a fatty meal.
Also keep in mind, obstruction of bile flow can mess with vitamin K absorption, leads to prolonged bleeding times.
Education. Avoid fatty, greasy foods, alcohol triggers. Gold standard diagnosis is an abdominal ultrasound.
Signs of a blocked bile duct include jaundice, dark urine, those clay-colored stools, and that intense itching pruritus.
And remember the risk factors, the 4Fs. Female, over 40, fertile, and fat, meaning obese.
Post-op care for a lap call, referred shoulder pain from the CO2 gas, is common. Get them ambulating early. Do not apply heat to the area. Put them in Fowler's position.
Acute management, NPO, IV fluids, pain meds.
All right, let's hit the genitourinary organs first. Benign prostatic hyperplasia, BPH. Hallmark symptoms are all about urinary flow. Weak stream, hesitancy, straining, frequency, nocturia.
Patient education points. Avoid fluids a couple hours before bed. Limit caffeine and alcohol. Go when you first feel the urge.
Post-2RP, that's the prostate resection priority, is keeping the continuous bladder irrigation, CBI patent. Outflow should be light pink.
If you get bladder spasms and the outflow stops, suspect a clot. You'll need to manually irrigate. Watch out for TURP syndrome 2, hyponatremia, confusion, hypertension from absorbing irrigation fluid.
Drug therapy includes tamsulosin, Flomax, relaxes the bladder neck, and finasteride, Proscar, actually shrinks the prostate.
Assessment via DRE usually shows an enlarged, firm, smooth prostate.
Okay, renal calculate kidney stones. Hallmark symptom is renal colic. Excruciating, sharp, flank back pain radiating to the groin. Patients often can't sit still.
Nursing care focus. Pain management is critical. You must strain all urine to catch stones for analysis. Push fluids, 2-3 liters daily, non-sugary drinks.
Primary prevention. Dehydration is the #1 risk factor. So fluids.
Surgical intervention might be lithotripsy, ESWL, breaks up the stones. Common types are calcium oxalate, calcium phosphate, uric acid, struvite.
Post-lithotripsy, expect some bruising on the slank and hematuria. That's normal. Hematuria is also common with the stones themselves.
For hypospadias, the definition is the urethral opening is on the ventral or underside of the penis.
Critical newborn consideration. The infant should not be circumcised. They use the foreskin for the repair surgery.
Surgical goal is to get the meatus to the tip for normal voiding and sexual function. Post-op, they'll have a catheter or stent. Use double diapering, inner for stool, outer for urine, keeps the site clean.
Activity restrictions. No straddle toys, rough play, tub baths. Meds like oxybutynin are often used for bladder spasms.
And the nurse has to monitor urinary output carefully. Make sure that stent isn't blocked.
Last one for this section, UTIs. Atypical presentation in the elderly is huge. New onset confusion or combativeness is often the main, sometimes only, sign.
In kids under 2, it's common, often with vague symptoms or just a fever of unknown origin.
Diagnosis. Get a clean catch, midstream urine specimen before starting antibiotics for accurate results.
Key prevention. Wipe front to back. Void right after intercourse. Upper UTI, pyelonephritis, involves the kidney fever, chills, flank pain. Most common cause overall, E. coli.
Hallmark symptoms of cystitis, the lower UTI, dysuria, burning, frequency, urgency.
Education. Emphasize completing the full course of antibiotics. And some key no-nos. No douching, no spermicidal contraceptives, and no perineal deodorants, and no synthetic fabrics. Cotton underwear is best, and no bubble baths.
Farm? Broad-spectrum antibiotics like Bactrim are common, macrobid or nitrofurantoin for sulfa allergies, and phenazopyridine. Pyridium, this is just a urinary tract analgesic for pain relief.
And it's normal for pyridium to turn body fluids bright red-orange. Totally expected, no need to report it.
All right, inflammatory and infectious diseases. Let's start general. The inflammatory process. It's adaptive, non-specific. Involves removing damaged cells, bacteria, exudate via phagocytosis.
And the 5 cardinal signs. Classic. Redness, warmth, swelling, pain, and impaired function. Remember, the suffix itis usually means inflammation.
Stages include vascular and cellular responses, exudate production, repair, regeneration, or replacement. Tests, ESR and CRP will be elevated.
Now, isolation precautions, super important. Airborne. Think MTV measles, TB, varicella, needs a negative pressure room. Staff wear a fit-tested N95 respirator. MTV live on air.
Droplet, think pertussis, influenza, meningitis, pneumonia. Need a surgical mask and eye protection within 3 to 6 feet. PIEMP drop.
And C, difficile specifics. Alcohol hand sanitizer is ineffective. Must wash with soap and water. Use bleach for surfaces.
Putting on PPE, donning, gown, mask, goggles, gloves.
Taking off, doffing. Gloves, goggles, gown, mask.
Contact precautions need gown and gloves. Think MRSA, VRE, scabies.
And patients on airborne or droplet need a surgical mask if they leave the room.
Moving to influenza, the flu. Transmitted by droplets. Hospitalized patients need droplet precautions.
Here's a critical medication warning. Never give aspirin to kids or teens with viral symptoms. Risk of Ray's syndrome, serious stuff.
Best prevention, annual vaccination, hands down.
Antivirals like oseltamivir work best if started within 48 hours of symptoms. Key symptoms: abrupt fever, myalgia, headache, fatigue.
Contagious from 1 day before symptoms up to 7 days after. Differentiating from a cold, flu hits suddenly with high fever and bad body aches.
Okay, conjunctivitis, pink eye, mostly caused by hand-eye contact, including fecal hand-eye, spreads rapidly, often starts in one eye.
Pharm therapy can include antibiotics, antivirals, anti-inflammatories, specifics, ceftriaxone for gonococcal, oral erythromycin tetracycline for chlamydial, parenteral acyclovir for neonatal HSV. Viral usually isn't treated, except HSV.
Prevention is key. Meticulous hand washing, avoid touching eyes. Wash discharge away, wash linens often. Don't share eye drop dispensers. Critically, no contacts during infection, discard used ones.
Otitis media, middle ear infections. Kids are higher risk. Their eustachian tubes are shorter, wider, more horizontal. Easier for fluid to get trapped.
Otoscopic exam shows a red, bulging, non-mobile tympanic membrane.
Ear drop administration technique, under 3, pull pinna down and back, over 3, pull pinna up and back.
Prevention. Breastfeeding helps. Bottle feed upright. Vaccinations against strep pneumo and H flu. Avoid smoke pollution. Smaller daycares might help.
Myorrhectomy is surgery to put tubes in for drainage. Complication: pus can rupture the eardrum. Fluid can cause temporary conductive hearing loss.
Behavioral signs in infants: pulling at ears, irritable, maybe fever.
Next, pneumonia, the earliest sign of hypoxia, often a change in mental status. New onset confusion, restlessness, agitation. Brain is super sensitive to low oxygen.
Priority interventions: high Fowler's position. Encourage incentive spirometer.
Likey.
Increase fluids to thin secretions.
Clinical picture: besides altered mental status, fever 100.4 degrees F, productive cough, yellow sputum, fine or coarse crackles, dyspnea, pleuritic chest pain with a pleural friction rub.
That pleural friction rub with chest pain. Biggest sign it's getting worse. I must report to the provider. Hospital-acquired is often nastier, more resistant bugs.
Pharm: antibiotics after grand stain, CXR. Bronchodilators, non-pharm fluids, IS, chest physiotherapy.
Definitive diagnosis is a chest X-ray showing infiltrates. Pleuritic chest pain is sharp, worse with deep breath or cough.
Remember, get the sputum culture before the first antibiotic dose. Prevention: encourage flu and pneumococcal vaccines.
Finally, tuberculosis, TB airborne transmission. Requires a negative pressure room. Staff need an N95 respirator.
Hallmark symptoms of active TB: persistent cough, night sweats, low-grade afternoon fevers, unexplained weight loss. Latent TB is usually asymptomatic.
Definitive diagnosis for active disease: a sputum culture positive for acid-fast bacillus, AFB. Treatment is long, 6-9 months because of resistance.
Initial phase, first 2 months. Isoniazid, rifampin, pyrazinamide, ethambutol, RIPE. Remember, rifampin causes orange body fluids. Continuation phase, next 4 months. Isoniazid and rifampin, RI. Might go longer, like 9 months with HIV.
Prophylaxis for exposure: usually single drug, isoniazid on NH daily for 9-12 months.
Latent TB, positive skin test, negative CXR, no symptoms. Not infectious, but might get INH. BCG vaccine causes false positive skin test, needs CXR or blood test. Active TB is reportable.
Okay, let's nail some high-yield pharmacology. First, phenoxypyridine, or pyridium class, urinary tract analgesic. Critical fact: it's not an antibiotic, only treats UTI pain.
Most unique side effect: turns urine bright red orange. This is normal and expected. Don't report it, but tell the patient. It will permanently stain clothes and soft contacts. Wear glasses.
Report yellowing skinnies, though jaundice means potential hepatotoxicity. Only take it for 2-3 days. Take with food.
Next, rifampin, TB antibiotic. Most unique side effect: harmless red-orange discoloration of all body fluids, urine, sweat, tears, saliva.
Critical teaching: stains soft contacts permanently. Wear eyeglasses. Also, major interaction: significantly decreases effectiveness of oral contraceptives. Need backup non-hormonal method.
It's hepatotoxic, too. Avoid alcohol. Report jaundice. Take on an empty stomach. Compliance is vital.
Finally, INH, isoniazid. Primary TB antibiotic, major adverse effect: peripheral neuropathy, numbness, tingling in hands, feet.
That's why pyridoxine, vitamin B6, is given concurrently to prevent the neuropathy. Like rifampin, it's hepatotoxic. Avoid alcohol, monitor liver function.
Must be taken on an empty stomach. Strict compliance is crucial. Cornerstone drug for active and latent TB.
Wow, you've just powered through a massive amount of crucial information in record time. As you head into your exam, remember, connecting these facts to real-world patient scenarios really solidifies it.
You think about how many conditions overlap. Like altered mental status could be pneumonia, UTI in the elderly, even advanced liver disease, right? Keep synthesizing. Keep connecting those dots. You'll do great. Good luck.